Mean arterial pressure is a number everyone targets, but few understand the nuances of it. If your next patient has a mean arterial pressure of 65 millimeters of mercury, most of us would feel reassured. But here is a trap. A normal mean arterial pressure can coexist with ongoing organ hypoperfusion because a mean arterial pressure is not perfusion, it is just a pressure. It can coexist with tissue hypoperfusion because mean arterial pressure represents the driving pressure, but true perfusion depends on perfusion pressure, which is actually mean arterial pressure minus downstream pressure. It will be either central venous pressure or intracranial pressure if it is in the brain. So a high CVP reduces renal perfusion gradient. A high ICP, intracranial pressure, reduces cerebral perfusion pressure. Additionally, microcirculatory flow may be impaired despite adequate mean arterial pressure due to endothelial dysfunction, capillary shunting, and mitochondrial failure, which are very common in severe sepsis patients. Thus, macrohemodynamics, getting it all right and tweeting it does not always ensure microcirculation is happening perfectly well. In sepsis PAM trial, which came in NEJM in 2014, showed that mean arterial pressure of 65 to 70 versus 80 to 85. No overall mortality difference was seen. But in the key subgroup finding was that chronic hypertensives had less AKI at higher mean arterial pressure targets. And in the 65 trial in JAMA 2020, in elderly ICU patients showed that permissive hypotension, that is making MAP okay in 60 to 65 and tolerating that, was safe and was associated with less of vasopressor exposure. Now, a patient with a MAP of more than 65 raising lactate and oliguria has definite hemodynamic coherence failure. What does it mean? Restoring MAP has failed to restore tissue perfusion and tissue is not still being adequately perfused. Also, excessive vasopressors can cause intense vasoconstriction and microcirculatory collapse, increased afterload and decreased cardiac output, all being counterproductive in the long run. So always use the stress test your MAP target, that is mean arterial pressure target. Is this MAP adequate for this patient should be the question before you aim a single MAP in all the patients. So adjust the MAP along depending on the chronic hypertension. Aim the MAP higher. High CAP, example RV failure, need a higher MAP. Neuro patients, target central perfusion pressure, not MAP. Capillary refilling time of more than 3 seconds despite an adequate MAP of 65 says that it is inadequate perfusion. You need to raise it. So in ICU hemodynamics, MAP is the target, but perfusion is the truth.